My name is Joe Paulini, and I'm CEO of Chexout. Back when I did volunteer economic development work in the Philippines, I can remember traveling the roads in northern Luzon. Good roads, modern poured concrete roads that would come to an abrupt end. You would then ease your vehicle off the edge of the pavement and bounce along ruts and bumps until you reach the next stretch of roadway, sometimes only 50 feet away from where the road just ended. When I asked my driver why, because there were no construction vehicles or any obvious drainage issues, and the road was relatively level anyway, I was told, Mr. Joe, they just haven't connected them yet. I would pass through some of the same areas a year or two later, and they would still be like that. It didn't make any sense. Why let those gaps happen and persist? That is kind of how I see public health system today. You're expected to keep things moving, even in emergencies, but forced to live with major gaps. This pandemic raised some very obvious questions about the capabilities and tools public health has available to it. Let's start with the first question. Why not have the software solutions needed all in one system? Why should you have to patch together systems that do only one thing, even if it's done well? Patching segregated systems together creates infrastructure redundancies and frustrating inefficiencies. Having one system for isolation monitoring, one to manage clinics and testing operations, another to deliver patient test results, still more systems to manage data for surveillance and reporting, and yet another for contact tracing, just doesn't make sense. You can't afford such inefficiencies, especially when your jobs are to quickly respond to emergencies. How can you be prepared when you're using different systems that don't communicate well together or easily? In the early days of COVID, Chexout was chosen by the CDC from a field of nearly 50 competing companies for its national contact tracing pilot program. We were chosen not only because we had ready-to-go software specifically designed for disease surveillance, contact tracing, case management, and symptom monitoring, but because our solution was truly an end-to-end software solution, from patient and clinic management to surveillance and reporting. It was all linked together. While the administration ultimately stopped the program, it validated our all-in-one approach to modernizing infectious disease control and management. Ours is a system that could be deployed quickly, was customizable, easy to use, and contained all the features an infectious disease management program might need. I'd like you to think about some of the stumbling blocks you face in responding to any infectious disease outbreak. Do you use open source free solutions that require in-department technical expertise that is not readily available? How many different systems are you using, and do they work together? What happens the first time you or a vendor makes a change? Who is responsible or even capable to make changes throughout the entire stack or ecosystem? Do you have to go to multiple places to gather data and then attempt to merge that data together before you can even begin analysis? In how many systems do you have incomplete data sets siloed off? Do you work with some of the big box software companies with no deep experience in public health surveillance and infectious disease management? And does it show? These may be questions you've been asking for a long time, but we're lacking the resources needed to make changes, despite the fact that you knew all along that little of it made operational sense. We spent a lot of time and resources and spoke to many informaticists, epidemiologists, disease investigation specialists, clinicians, and other infectious disease professionals to develop our software. From those hundreds of conversations, we developed the principles we believe are fundamental to working with public health, and I would encourage this of our competitors as well. Have a software that is out of the box ready, but flexible enough to be customizable to meet the unique needs of an individual health department. Be quick to adapt and customize features in days and weeks, and for more complicated customizations, months, not years. Have all the tools to support program needs, and let customers be able to choose the tools they need and not the ones they don't. Make it easy to be able to share data. Most importantly, be collaborative. Early this year, we signed a contract with Marion County, Indiana, In our startup meeting on February 2nd, we were informed that they needed our software fully functional and deployed for testing by March 1st. They were hosting the NCAA tournament in Indianapolis, and contact tracing would be a key need for them and for a successful tournament. Not only did we need to include some customizations, their required fields, and link up with their laboratory, but we needed to have their contact tracers trained and ready to use the software. It was a master class in collaboration. We committed to meeting their deadline, and they committed to making every resource available to us, while we, all of us together, made the deadline. This is one of the great lessons of the COVID era. You can do things quickly as a tech partner with public health. Don't be just a vendor. So what are some of the big lessons learned from this pandemic? Well, the most obvious lesson was we, as a nation and the world, were unprepared for a pandemic. The old patchwork of infectious disease management and control can no longer stand. We can no longer afford to have gaps in our systems. That is not to say we need one software system to address the entire infectious disease ecosystem, but we do need to acknowledge and understand that piecemeal and hodgepodge approaches are deadly. Being unprepared for the next pandemic, and there will be one, is unacceptable. Over 5 years ago now, in a famous TED Talk, Bill Gates warned the world that we were not ready for a pandemic.
Today, the greatest risk of global catastrophe doesn't look like this. Instead, it looks like this. If anything kills over 10 million people in the next few decades, it's most likely to be a highly infectious virus rather than a war. Not missiles, but microbes. Now, I don't have an exact budget for what this would cost, but I'm quite sure it's very modest compared to the potential harm. The World Bank estimates that if we have a worldwide flu epidemic, global wealth will go down by over $3 trillion, and we'd have millions and millions of deaths.
Sound familiar? Health experts warn that we are likely to see more zoonotic-based viruses because of the way man keeps encroaching on forests and wildlife. Who can say if the next one will be more or less deadly than the coronavirus we are still dealing with? What will we do to be prepared next time? Whether you are managing a coronavirus pandemic, an Ebola outbreak, an STD epidemic, measles, Shigella, you name it, the same tools and principles apply. Having the ability to rapidly respond and communicate with patients, monitor symptoms, manage test and lab results, manage a workforce of thousands, see data in near real time, visualize patient clusters and outbreak hotspots. These are the tools unified that will help prevent another disaster like this time. Chexout has worked with state, territory, county, city, and local health departments of all sizes, from Hawaii to the U.S. Virgin Islands, to help them modernize their infectious disease control and management systems. Inevitably, we were tasked with interacting with some of their current vendors. It was working with all these different partners over the years that helped shape how we as a company design systems and tools to meet their needs. My advice is that you are not looking for an all-inclusive software solution and are looking at piecing together different vendors and systems to meet your department's needs. Get your potential vendors together and get commitments that their systems will seamlessly exchange data and information, and get it in writing. You're all tasked with being ready to respond to the next health emergency. You deserve the best. Thank you all for your service.